Доброго вечора, українські радіаційні онкологи, медичні фізики і радіаційні терапевтичні технологи. Слава Україні! Дуже дякуємо, що приєдналися до SBRT SRS course for Ukraine with Astro APM experts. Help Ukraine Group, Astro International Committee, APM Clinical Education Subcommittee, RISE Contra Cancer, and SweCare are all excited to present this fourth lecture in the course, and the topic is treatment planning for SBRT and SRS. We have an amazing speaker today, Dr. Cesar Della Biancia from Memorial Sloan Kettering, New York. Dr. Della Biancia was born in Cordoba, Argentina. He obtained his degrees in physics and medical physics at the Universidad Nacional de Cordoba. He worked as medical physicist at Centro Oncológico del Litoral, Santa Fe, Argentina, from 1996 to 1997. And in January 1998, he moved to New York to join Montefiore Medical Center in Bronx as a medical physics fellow. And after the completion of the fellowship, he became a senior medical physicist at Montefiore Medical Center until October 2000. In November 2000, he joined Department of Medical Physics at Memorial Sloan Kettering Cancer Center. It's one of the biggest centers in the US. And he currently is an associate attending physicist. In addition to clinical roles, he is a director of the quality improvement section and the coordinator of treatment planning for MSK outpatient and alliances facilities. He oversees the treatment planning activities across the whole network, maintaining quality and consistency, and providing education and clinical support. Since 2012, Dr. Della Biancia primary research focus has been development and execution of audits of dosimetric quality and consistency in treatment plans across MSK enterprise. Valuable insights were made into limitations of education, communication workflow, technical processes. Currently, Dr. Della Biancia has been working on transitioning these audits to automated methods, including using auto segmentation, auto planning, auto QA to assess plan quality on a much larger number of patients, develop quality metrics, and feed these metrics and audit results back into the processes to continuously improve patient care. Dr. Della Biancia is greatly involved in national international education. He's currently a board of directors members at APM, ABMP, and the local chapter. And he also previously taught in the APM Hug WAMP course for Ukraine, for which we're really, really grateful, and this course received an award at APM. And today he's teaching on SBRT treatment planning. So thank you so much for preparing a great lecture for us. Please, the podium is yours. I'll stop sharing.
Thank you so much, Natalia, for your amazing introduction, and good night, I guess, to everybody. Here we still have daylight, and I'm very happy and honored to be part of this course and share as much as we can to our colleagues everywhere else. So it's very important for me also, as well as for you, to be here together. Okay, so as Natalia said, today my presentation is going to be focused in treatment planning on SRS and SBRT, and basically the foundations of the treatment planning, because I know that you have lectures for specific sites, and then you will have more details for those sites. This is just a general overview of planning on SRS, SBRT. No conflicts. So basically, we all know that the main goal of the SBRT is just to ablate tissues within the PTV. So the dose inhomogeneity inside the PTV is considered, in this case, is an advantage. We have this is what we need to change our mind between a 3D plan or not a 3D plan, a conventional fractionation plan when we want things very homogeneous, not high hotspots. Here, sometimes because we wanna we appreciate the rapid fall off of the dose outside the target because we want to protect the organs because now we're working with higher doses to the PTV. So inhomogeneity actually is an advantage. So we shouldn't be um, looking for making very homogeneous plants within the PTV. So that's one of the difference from conventional fractionation. And in the SBRT practice, basically it's very important to make sure that everything is accurate. But throughout the whole entire treatment delivery process, which is basically an integration between, we need modern imaging, uh, good simulation processes and procedures needs to be changed, including immobilization devices and all that. Treatment planning, of course, which is our focus today, and also the delivery technologies, which is very important. I mean, certain things, we can make very amazing plans, but if we don't have the machines prepared to deliver that very accurate and small lesion plans and high doses, then it's going to be a problem. So one of the main also characteristic of SBRT is that we will use a large dose per fraction. Normally, we'll talk about above 600 centigrade, and it can go up to 2400 in one fractions for SRS, even more. And these fractions are delivered in fewer fractions, from one, what we call SRS, and up to 5. That's basically by definition of SBRT. Large dose per fraction delivered in few fractions, 1 to 5. Normally, ideally, we would like very well circumscribed tumors, meaning that the tumor that we're going to be giving a lot of those, they cannot be huge because if let's say if you have a massive tumor and we're going to be give a high dose per fraction in few fraction, then the rest of the is not what there are other techniques that they're developing now for large tumor for that, but in concept, normally we want around diameters around less than 5 centimeters. And for example, if you have something that is a little more than 5 cm, maybe 7 cm, something like that, maybe you can use the lowest fractionation that we have, which is 600 centigrade times 5 fractions, sometimes even 500 centigrade or 400, depending on what you're treating. Another big characteristics is now, compared to conventional fractionation, that we're talking about very small margins between GTV, CTVs, and PTV, or sometimes no margins. For example, there is this lung SBRT, which you can see from the CTV to the PTV, there is only 5 millimeters. For this brain SRS tumor, we have a 2 millimeter margin between GTV and PTV. So very, very small. And you can see how small the lesions are. And for example, for a paraspinal SRS case, also sometimes we put a 2 millimeter margin between the CTV and the PTV. So this is something that needs to be very important to realize, because as I said before, if you don't have the technology or the imaging that's to prepare the machines in order to make sure we deliver the fraction to the dose per fraction to the PTV, and then we don't have a good immobilization or good way to detect if we're in the same position all the time, then we're gonna be having trouble. We might miss giving those to the target because the margins are very small. In conventional fractionation, we have a little more freedom because the margins sometimes are 1 cm and above. So as I said before, so there is a big need for good patient immobilization, and also respiratory motion management is very important. I'm not going to talk because probably you haven't talked about that, or maybe not in this court, but it's not the focus on that, but motion management is very important when we're talking about SBRT, especially in the thoracic area or abdomens. We also will need a higher frequency of patient monitoring and geometric verification through imaging guidance. So that's what we call IGRT. So basically, we need to have tools in order to make sure that during the treatment, we're treating the correct area and patient didn't move or things didn't move inside. So you need to basically have high IGRT technique. And very, very important, actually, SBRT requires training of all the staff, not just physics. Is physicians need to get used to the new volumes, new way to they prescribe treatment, new ways to see plans that we provide. Also the nurses, because they need to make sure how to prepare the patient, radiation therapies, dosimetries, and physicists. As you can see, the training is for all. And this is a very important point. Not just sometimes we think, okay, well, as long as the machines are ready, physics did the plan, we can treat. It's not. It shouldn't work like that. It's a teamwork. So we don't want to be like the picture here on the bottom that we're trying to see if we hit the target, and the poor physicist there is sweating with a little ruler and I don't know measuring what, but it is we don't want that basically. So then we're going to go to the first Zoom poll question. And I think, Natalia, you have prepared the Zoom. So I'm going to be reading the question. The major characteristics of SBRT are A, large CTV to PTV margins, large dose per fraction, few number of fractions, 1 to 5, tumor with maximum cross-sectional diameters more than 5 cm, A or B, A and B, C and D, B and C, B, C and D. Maybe a little confusing, but pay attention. Pay attention on A, B, C, and D first.
Okay, we'll wait until approximately 80% answers and then end the poll. How many percent of your patients are SBRT?
I will say that we have I would say 60 to 70% our patient has SBRT. We have
Amazing.
yes. So that's another thing. SBRT grows quickly. When you start, you should start slow, just big
Yeah.
size. We started with prostate, for example, long time ago.
Right.
But then everything started to, yes.
Impressive, impressive. So we have 95% participating. Thank you for your participation. So I'm ending the poll and sharing results. So what we see here, the majority answered G, options B, C. So that's around 50% of people. So would you like to comment?
Yeah. So basically, I mean, option A, we said that the margins that we want between CTV and PTV, they are not large. So they are normally below, they are millimeters. Okay. So that was not a good answer. B was correct, large dose per fraction compared to conventional. C correct, few number of fractions, 1 to 5. And D maybe was yeah, we said that we want tumors less than 5 millimeters. So basically, yes, B and
Centimeters, right? 5
yeah,
centimeters.
5 centimeters. Oh, sorry. B
Okay.
and C is the correct. So it was more, maybe I should have clarified it could be more than one, because some people say B and C, which is okay. Yes, they are. B and C will be okay, but not E is not because A is not correct. F, no, because D is not correct. Okay.
Sounds good.
Perfect. Moving to the next slide. I know that probably I don't know if you have a talk about technology, but I wanted to talk a little bit about the different technology. So, because sometimes people said, oh, or you hear a presentation about SBRT, and if a particular person works with just one type of technology, they think, oh, I don't have that, I cannot do SBRT, but that's not the case. There is many type of technology, and because of that, they can be different treatment planning strategies. that we all follow the same characteristics that we and more things that I'm going to explain later. But I want to make sure that everybody is aware of the technologies that we can use or they've been used in the past. And we have this Siemens Primatron. Tomotherapy is also used to do SBRT. A gamma knife, very, very used for SRS, brain SRS, and still being used a lot. CyberKnife is another. And then we have all the Linux, what we call the Linux-based technology, which again, it doesn't need, you don't need, and I put few examples here. You don't need to say, oh, I have variant, I can only do variant. No, I mean, every machine can do SBRT, Electa, Siemens, all the machines, all the above. So as you can see, there is a big plate with option of SBRT. The most important thing is that you just to make sure that the machine is up to the standards to perform SBRT treatments. So, and again, I'm not going to focus a lot, but I just pick some of them just to give you the little difference between the technology or what or important things per technology. Like gamma knife, for example, we all know that is a lot of cobalt 60 sources, and they focus is focused on spherical distribution. So the isodose lines are designed via either cone diameter or plugs, and the prescription normally for this type of treatment or when you plan is 50% isodose line, and this is mainly used for cranial SRS treatments. And again, this is something that is still very well used and is in the practice. And maybe I don't know if there are many gamma knife machines in Ukraine, but probably they are. They're not.
No.
Okay,
Zero.
zero. Okay, but okay, it's an option. Then we have CyberKnife, and again, I'm gonna ask, do you know if there is CyberKnife?
Yes, there's one cyberknife in Ukraine.
Perfect. So, okay, CyberKnife it has a robotic gantry and a set of circular cone on or iris apertures, and basically, typically, because this gantry will be going in any direction when you plan, it can be up to 200 beam angles, and you can see that it's not like the regular gantry on a machine that goes 360, and then we can rotate collimator and the couch to give us. Here it can come from any any part and focus on the target. And basically it has a 2D KV for setup and interfraction motion monitor embedded in the machine just to track the treatment. This is how the collimators look like. You can have 12 fixed collimator between 5 millimeters to 60 millimeters of diameter. And the iris, we have the iris variable collimator, which is blades with the shapes up to between 5 millimeters to 60 millimeters in diameter. So again, these are just to give you the difference between when we're going to talk a little more about Linux. And I'm going to focus on, because this is what you use the most, okay? And then just to give you some ideas on the treatment planning specifics for the CyberKnife. So basically, it's very important to select is a selection of the imaging center, because that's going to be the center of, normally there are fiducials to track during treatment, and normally they used to put that imaging center in the center of part of the fiducial, or you can select if you have other tracking nodes, you can select it somewhere else. The contouring is very important, but actually contouring is the same, and I'm going to go through the same as Linux base. Collimation selection here, basically, because it's different than the Linux. So you have to try to find a balance, conformality and treatment time. You don't want to have long treatment, so you don't want to select a lot of type of beam angles and collimation difference, so that because the treatment is going to take a long time, and usually use multiple collimators to achieve this compromise. The beam targeting, you can the points are randomly generated within or near the boundary of the target VOI on the central axis of the beams in the beam set. And the optimization is you need to optimize the dose distribution based on user-defined constraint. It's kind of like inverse plan. It's like regular inverse planning. And then basically there is a feature here that you have a beam and a mu reduction. Basically, you can use that so you can basically make the treatment more efficient and not too long, because we can be very creative in CyberKnife, but there is an automation and suggestion by the system how to reduce that. And actually, some of the structures, they fix a number of constraint points. They're fixed numbers of constraint points in the grid. So you can set tight limits around the structure. Basically, they use a lot of this shell structure to tune the isodose line, which we use the same, like inner shells or rinds, things that we use also for planning on Linux base. And sometimes you use additional isolated manual constraint points to fine tune the dose distribution when these shell structures don't work very well. So you can always manipulate that. And I have a couple of examples here very quickly how the distribution you will see it looks, I'm sure when you see examples of Linux base, it's very similar to what we have, but you can see all these little points here. This is all the entrance of how the beam is going to be, or the robot is going to be entering to the patient. That is a paraspinal. We have a prostate example, and then we have a liver met. And again, these are things that you can come across if you're, whoever is involved with the CyberKnife there. And just to focus more on the Linux base, we have a large variety of machines. So for example, for the Variant machines, we have two types of MLC, the Variant Millennium 120, which have lips 5 millimeters in the center and 10 millimeters outside the lips, and Variant High Definition MLCs that have 2.5 in the center and 5 millimeters outside the lip. Why I wanted to point this out, because for example, when we talk about SBRT, we talk about small targets. So of course, if you have a high definition MLC with the small leaves in the center and you use that to treat, you achieve a little more conformality in the plants, because the leaves can move more, the leaves can shape better around the contours. But it is not that you must have that to do SBRT. You can do SBRT with a Millennium 120 as long as the machine is prepared, calibrated with tight, all the requirement for the SBRT calibration. So both are good, but you need to check what you have and what is important. So this type of flip, for example, we will give you flexibility for you can use a static beam, but it's very rare that we will use a static beam for SBRT. Normally we use dynamic conformal arc. I'm talking about Variant, IMRT, or VMAT, so which you are familiar with those type of deliveries. If we talk about Electa Linux, again, it's the same concept of multi-leaves. The only thing, for example, they have the multi-leaves are a little bit different. So, for example, the Versa, just to give you one, you have many types. It has 160. It's called agility. Field size is 40 by 40, and the leaf thickness are 5 millimeters. So some other accelerator, they have 10 millimeter leaves all along, and the number of leaves changes. It's just to give you an idea, same as the Variant. And then for Siemens, actually, is the Siemens linear. They are equipped with 160 MLC, 5 millimeter leaps, and here 40 by 40 is the field size, and that's the linkage, which it's important, but not that important. But again, with this, I wanted to tell you that, okay, if any of these machine you have, you can perform a CRT, again, as long as the machine is basically QA and make it ready to deliver SBRT. Not only the machine, but also your imaging, your IGRT system and tracking. So, and then we can go to the second Zoom poll. And I say here, which equipment are appropriate to use for SBRT treatment? And one is the Gamma knife, two is an X-ray superficial RT unit, three CyberKnife, and then four is a Linac with OBI system. And you have a combination of numbers.
Cesar, you listed all the machines. What are the machines that you have at MSK?
Okay.
Yeah,
We have variant. We have a
all
variant.
variant.
All
How
variant. We have 30, 30 accelerators.
30?
30.
30? Oh my goodness.
Just
Okay.
because we have 10 in the main campus and we have
Yeah,
6 regional clinics with 3 or 4 each. And they're all, at this point, they're all true beams. We have
true
updated
beams.
mostly to true beams. But
Mhm.
also we have a Unity, an MR-Linac Unity.
Okay. Mm-hmm.
That's the
Sounds
only
good.
Electa thing that we have.
What about Cyberknife or Gamma
No,
Knife?
no, we
No.
don't have CyberKnife, we don't have Gamma Knife. So we
Okay.
basically do all our SVRT, SRS, Linac base.
On true beams. Okay,
True
great.
beams, on true beams. Yeah.
And do you have HGMLCs on those or?
Yes, we have 2 machines
Mhm.
with high definition. But again, the second is we function with one machine was only high definition, and we normally this is what most of the brain, cranial, multi
Okay. Hmm.
treated there. But then in the regional campus, they don't have it, so they still treat, and we have limitations on the size of the lesions.
Right, right.
So those are things, but it can be done. Okay.
Yeah, great. Okay. So 87% participated. Thank you for participation. And in the poll sharing results, so majority answered D, 134.
Mhm. Yes, 134 because it's Gamma Knife, Cyber Knife, and Linac. And this X superficial RT unit, I've never heard that it's been used for SBRT, but if any had, let me know because this is mainly to treat. I mean, they might treat high dose, but not even. But this is mainly to treat superficial lesions. Sometimes they do high dose, but that's not considered SBRT because these machines are, not they don't belong to the SBRT family, I guess. Okay. So moving to the next slides. So I'm going to talk a little bit about contouring. And contouring, again, is very important. I mean, it was always important to contour targets and organs rigs, always. But this for SBRT, you need to be a little more careful just because the dose per fraction that we're giving to the PTVs, and you remember that the margin between GTV, CTV, and PTV, they are very small. So organs as risk that they're very adjacent to that, they need to be very well defined because a couple of millimeters difference, they might make a big difference on the constraint, on the evaluation, and all that. For example, for this paraspinal SBRT, look, you have the PTV, which is in red, and what is the main structure there that is abutting basically the PTV is the core. And we know that we have very limited, maximum dose limitation for the core because we can cause a lot of damage. So that's why it needs to be contoured very well. For example, in this case, and again, I didn't want to include a lot, but this is a case that we use myelograms to define the core. So basically the myelogram is an injection, is the dye injection that you put while the patient is being simulated. And basically you can see here very well the true core. But if you do not have that, because sometimes in some places they don't allow it, or patient is
Mhm.
allergic, or they don't use it because it's a little bit, it's something else, it's a procedure, you can do an MR. I mean, and then we fuse the MR with the CT, and because in the MR with certain sequences, you can see the true core very well. So you contour, but what we do in those cases, because we're adding an uncertainty how well the fusion was done, we use a PRV instead we add a PRV core with a 1 millimeter margin, just to account for uncertainties on the fusion, on the registration. Okay, so that's the only difference. If it's myelogram, we treat it, this is the core. If it's because it's very well designed and it's the same scan. But if it's a registration with any other type of imaging, you need to make sure that you add that PRV. And here, for example, we have a prostate case with, again, you have a lot of like the rectum is right there, the bladder is right there. And one thing, if you notice the contour in between the CTV, the CTV is green, then you have the PTVs red, you have a yellow contour like that. That's basically, that's a rectal spacer that we add for prostate cases. Since when we started SBRT, we thought that it was better, in order to protect the rectum a little more, to add this spacer, which is a gel that is injected into the patient and then reabsorbed after the patient is done with treatment in a few weeks, but it stays there and basically separates the prostate, the CTV, which is the prostate, with the rectum. So you have a little more room to give a lot of more dose to the PTV and CTV, protecting the rectum the way that you want to protect them. Again, this is something that when we developed our SBRT prostate is something that we kind of did it. We do it for all patients. If you cannot put that spacer, there are other things, and we have other constraints. So we create structures to basically we compromise a little more the dose to the CTV, because you still need to maintain the constraints for the rectum that high tech tell you, and I'm going to talk a little bit later. So again, that's what is very important the contouring session is very important. The margins, again, actually, I talked a little before, but I want to talk a little more now. In many cases, CTV is kept the same as GTV. For example, for brain metastatic, we just contour the GTV and then we put a PTV at 2 millimeters. So basically, the CTV is the GTV. So the expansion from the CTV to the PTV depends on the correction utilized for the tumor motion manager between 0 to 5. And why is that? Because if it's a tumor that is in the liver, for example, that you know that it's going to move because it's going to go up and down. So you have to, if you did a little control, so you need to see how much margin you need to add in order to control the movement of that basically a tumor. So basically that's very well defined. The margins are very well defined and by the physician. The physicians will know, but also is the talk with the physicists, because the margin also is going to depend on the immobilization devices that we're using. You want to make sure that the patient is mobilized within millimeters. And then here, for example, you have a case of the prostate where we normally, this is the normal margins that we use. We use 3 millimeters from CTV, which is the prostate, to the PTV is 3 millimeter posterior by the rectum and 5 millimeter all around. And that's our standards. And then, for example, for a brain SRS lesion, the margin between CTV, which is GTV, and PTV in this case is 2 millimeter, but sometimes we do 1 millimeter, sometimes we do 0 millimeter, depending on the lesion and the patient clinical diagnostic too. In terms of beam characteristics, also, again, why when we talk about SBRT planning, we need to think about, okay, because now we're delivering a lot of MUs, more MUs than a conventional, because the dose per fraction is a lot more. So how can we use to basically we need to also help to increase the dose gradient in the boundary of the PTV. And most of the time we include non-coplanar fields, especially on the brain. I mean, in other parts of the body, you need to be careful with the non-coplanar, but for brain, it's very important that you come with different direction that will help you a lot to create that dose gradient. Okay, so, and also the use of flattening filter-free beams is a good advantage just because they have a higher dose rate. So that means the delivery is going to be quicker. So there's going to be a reduction on treatment time. And basically, this will also help if the delivery is less, it's going to help you to avoid motion during treatment, because basically you will give the patient a little less opportunity to move, or if the patient, if because the treatments are quicker. Okay. And here I just want to, since we're talking about different technologies, I wanted to give you the characteristics of some of the FFF beam from Varian, Electron, and Siemens. So you can see that they have some type, some varieties on energy, and those rates, they vary depending on the energy and also the vendor, correct? But they are in the above 1400, 24, between 14 and 24. Then when we talk about margins, remember for classic planning, so normally if the beam margin is close to the beam penumbra, close, not between 5, meaning the margin of the MLC lips are 5 to 6 millimeter away from the PTV, normally you're going to have an homogeneous PTV dose. You most probably going to achieve maximum doses in the plan about 110% or less, most probably, of the prescription dose. And the dose fall off outside the PTV is going to be slow, because you're not, this is the regular way that we plan. We normally, when we plan conventional fractionation, we always have in mind that we cannot put the distance between the MLC or the border and the PTV has to be more than the penumbra of the field. But if the beam margin is less than the beam, or much less than the penumbra, between 0 and 2 millimeter, what is going to happen? We're going to be using penumbra to, we're much tighter. So the dose distribution is going to be more inhomogeneous, which is something, remember, that we said that it is advantageable for because we want a rapid dose fall off. And the third item here, the dose fall off outside the PTV is fast, because what is that? We can basically make the doses to the OR adjacent less quicker. But because of it's very homogeneous, the maximum doses, don't be surprised that they're going to be about 125% or even more of the prescription dose. For example, for SRS cranial, we even go to prescribing 200% to the PTV. We go to 140 sometimes, but it's within the lesion, so we are okay with that. So this is something that you need to keep in mind about the margins of the beams, okay, and the PTV. Now the margin, I'm not talking about margin between CTV, PTV. We know that those are small. This is margin between the beams and the PTV, or your leaves and the PTV. Also something that is, again, these are tips and advices. So when we open the jaw open is twice as much when we compare. Normally, I mean, again, there are some cases, there's some there's people can tell you that SBRT, they need to be done with if you collimate 45 degree, you have good plans. But for example, when you collimate 0 or 90 degrees, you have a lot of less leakage in the area, where the arrows are, because here the lips are closed, but this is going to be moving. So it's unnecessary. This area, there's going to be leakage between the teeth. So why we want to have that? Of course, if it's a very large tumor, sometimes collimating is good, but I will be careful with the amount of collimation that you do. For example, what is advisable, if we do a combination in our institution, we decided to do a combination of fields per plan between 0 and 90 for most cases. But sometimes, for example, for head and neck, or for that, sometimes the fields can be a little larger. We do 5 degree in each direction, which it gives you more, a little more flexibility with the field size and less leakage on areas that you shouldn't have leakage. But again, this is something that needs to be resolved by institution. It's not mandatory. This is what I want to say. But be careful when you collimate to 45 degrees, because there's going to be a lot of leakage there. And make sure that sometimes um, that you control, when you do this plan, but that applies to any VMAT plan or rapid arc, that the leaps, the that there are not leap parks inside the jaw. So normally the systems are very smart when the leaf is not moving, so it will close the jaw. But for example, when you have collimation, sometimes there might be a leaf that is closed inside the field, and you will have a lot of leakage there. Those leaves, they're not going to be moving, but they're going to be having a leakage because they're not, that there is a 2 millimeter or a couple of millimeters between the borders. So be careful with that. Make sure that that's something that you check at the end of your planning. And then I think we can go to the Zoom poll number 3. And is the flattening filter-free beams have higher dose rate, which can be led to reduction of treatment time? Is this true or false? So basically, this is the if it's this characteristic of FFF beam is true.
Okay, so we have 88% answering. Thank you. Ending poll sharing results. So majority answered true.
Mm-hmm. Yes, and it's true because remember, I'm going to go back to the table that we have here that we said that the dose rate is high, which is what the statement said. And because of that, there can be a significant reduction of treatment time because even though you think, but the dose per fraction is high, so the mu's are going to be more. But because of, we're talking about treatment time, because of the higher dose rate, the beam is going to be delivered quicker. Okay, and MUs can be higher, but the delivery time will be reduced if you use FFFE because of the higher dose rate. Okay, so we can move to the next exercise. It's about the next exercise about dose calculation in general. So normally for SBRT SRS planning, because we have large dose gradients within the PTV. So basically we allow for this rapid dose fall off outside the PTV to spare normal tissue. So the dose calculations that we want to use small grids of 2 millimeters or less, just because we have the margins are small, you have rapid fall off, so we want more precise calculation with, in a smaller grids within 2 millimeters. And one topic that it requires a complete session is small field of symmetry. You need to remember that we said that some type of treatment, for example, SRS brain, we're talking about lesions of 1 centimeter or less. So you need to make sure that you follow what you need to follow to make sure that you the protocols to make to check this small field of symmetry. And for that we have a very good documentation. The report for 483 of the IAEA, which is a specific the dosimetry of small static fields used in external beam radiotherapy, and this is an article from 2017. And also the APM have a task group 155, which is about megavoltage photon beam dosimetry in small fields and non-equilibrium conditions from 2021. So here you have, these are very comprehensive. They will tell you everything that you need to do to make sure that you can treat small fields in your machines, basically. You make your machines ready because it has to be with the algorithms, not just the QA of the machine. You need to learn how the leaves move, the DLG, the leak, everything. And they're very important. But again, these require another course or many courses because there is a lot of information, and it's very important when we go and we want to start an SBRT program. Okay. The prescription dose is very, we know that it's high doses and different. I mean, you're going to find some institutions that they prescribe instead of 100%, they prescribe to lower isodose level, 80 or 90%, which is common, very common. And then basically, when we talk about SBRT and SRS, they are radiobiological models to compare treatment regimens between the SBRT SRS with the conventional dose delivered. That's how basically it was translated, because we know a lot more about conventional fractionation because we have years and years of treatment. So there is a lot of toxicity report, there is a lot of TCP and TCP constraints with conventional. So how do we know that the dose that I want to deliver in conventional, what is the equivalent in SBRT, is all these biological models, which is has to do with biological equivalent dose, BD, normalized total dose, NTDs. And these biological indices are useful and to compare different fractionation schedules between conventional and different fractionation that you can create on SBRT. Because, for example, for lung cases in our institution, we have a fractionation of different fractions for 3 fractions, 4 fractions, or 5 fractions. And we need to make sure that the doses are biologically equivalent, how we translate. And these are all models. Again, this is probably another course, but this is something that you need to be sure where this comes from when we talk about SBRT and SRS. And then we can go to the next Zoom poll, which is the main beam characteristics for SBRT planning are, we're talking about the characteristics of the field of the beams. The beam margins is much less than the beam penumbra, 0 to 2. The maximum dose is about 1/10 of the prescription dose. The dose fall off outside the PTV is slow, and all the above. Remember, we're talking about SBRT, beam characteristic for SBRT.
All right, so we have 84%, if 85% answering. Ending the poll, sharing results. So majority, unfortunately, answered all of the above. D.
Oops, sorry. Yes. Yes, which basically the correct answer is A, because we know that we were talking about the beam, the margin between the beam, we use less than the beam penumbra, between 0 to 2. That's correct. Remember that we said I'm going to go back to the slide. For SBRT, we want the maximum dose because they're very homogeneous and we're using beams less than the beam margin less than the penumbra. We're going to be expecting maximum doses of 125 and above, not less than 110 like B was. And then the dose fall off outside the PTV, remember, is fast because now the beams are very close to the smaller than the penumbra, which is something is a quality for SBRT that we want. So so A was the correct answer. Okay. But again, we're all learning, and probably because I also gave you the other slides and we talk about 110 and PTP slow, but I wanted to give that's basically what happened in conventional. For SBRT is all the other characteristics that we just said. Moving on, in terms of evaluation criteria, we all know, and it's very famous, that for conventional fractionation, there is this Quantec articles that they have a lot of information about tumor control and normal organ at risk constraints for many sites. And there's been many publications on that. Very well established for many years of practice. But for for hyperfractionation, because we started like, let's say, some years ago, less than conventional. So they finally, there was this publication which is called high tech, which is basically the equivalent of the Quantec, but for hypofractionation, because it's a high dose per fraction, hypofractionated treatment effects in the clinic. So basically, this was a report that it was done by oncology, radiation oncologists, physicists, and radiation biologists, because there was a lot of, remember we talk about these radiobiologic models, a lot of things needed to be converted, basically, or making sure that it makes sense from conventional to SBRT. And all these papers, they are published in a special issue in this magazine, the Journal of Radiation Oncology, Biology, and Physics. So, and this is from 2021, not, I mean, recent. Before, I mean, we started doing SBRT before. So what we were doing before, we data and comparison with the institution, we were creating our own constraint. But then, basically, now it's all formalized. And then in this high tech, also you're going to have a summary of NTCP estimate after SBRT and SRS, and TCP estimate from the hypergraph, which is this article here. And then, for example, this is a summary, it looks very busy, a summary of NTCP estimates, but I just make one bigger, for example, for the spinal cord, which is the structure that we always are afraid. So the endpoint, meaning like the injury that we can't, is a myopathy that we can do if we exceed doses. And you can see here how the doses are for the spinal cord or the canal or the thicker sac. With there is a lot of definitions in this report. So for 1, 2, 3, 4, and 5 fractionation schemes. So you can see how this is the limit, the Dmax of the spinal cord, depending the fractionation that you do. And again, there is a lot of radiobiology here involved and how to do it. But the same you will find for many other structure, bladder, liver, rectum, and all that. And then we have summary of TCP's estimates after SBRT. And again, there is a lot of those here, but just I wanted to make sure how this is kind of those schemes that you can do, the type of dose fractionation. For example, for lung, there are few different type of treatment that people use in 3 fractions with a total dose of 33 or 45 to 54, or even equal or more than 60 gray. So that means 2000 centigrade per fractions times 3. And again, there's many, you need to read what are the details in each. And then you have fractionations of, you have type of fractionation of 4 fractions that they are equivalent, like the 48 to 42 to 48, and more than 52. And then finally, the 5 fraction, which is the most typical that we use, depending the location of the tumor, is 1000 times 5, with a total dose of 5000 centigrade. Again, in this, there is a lot of information in this paper, but they are very comprehensive, and there are many articles too. Okay, so also, I mean, these are these are good articles, and you can follow that. But also, there is a lot of protocols that you can follow. That these things, institutionals have done research, and they become these RTOG protocols. So here I just named some of them, but there are many. But just make sure that your institution agree to follow that protocol. Always talk to the radiation oncologist. And also you have institutional constraint. For example, here I'm sharing our MSK constraint for a prostate going to 800 times 5, which is the typical fractionation we use. Prostate only, no nodes. These are all the criteria, for example, for the for the large bowel, the maximum dose is 29 grade or less, and that we follow. But again, I put it in red because this is very important. I can show it to you, but there is a lot of things behind these, why we came up with those numbers. Of course, they have a lot to do with high tech, for sure, but also depends of what immobilizations devices you have, if you use or not rectal spacer, if You have fiducial markers to track the prostate while you're treating to do IGRT. So that's why you cannot implement this constraint unless you evaluate them and you talk to this institution to say, okay, what are your conditions, and what is your planning technique in order to, or your planning criteria in order to follow this procedure. So do not, this is something important. If you create, do not implement shared constraints without a clinical review and institution approval. That's my message on that. And then we can go to the last Zoom question. And the question is, for a small field of the phrase is for a small field of symmetry is recommended by reports of IAEA report 483 and APM TG55 is not important for SBRT planning.
Okay, I'm ending the poll, sharing results. So majority answered B, false.
Which is false, because remember, those are the two big report that I said they are very important for SBRT planning, and it's about a small field of symmetry recommended. Okay. Okay, so in summary, basically we talk about this SBRT. You know that it's large doses per fraction delivered in few fractionations and single fraction for SRS. Remember that the margins between CTVs and PTVs are small or sometimes non-existent, between 0 to 5 millimeter. The use of flattening filter free is basically a nice thing, because basically you can use the higher dose rate to reduce the treatment times. Those calculations, they should be done using small dose grease, like 2 millimeter or less. Small field of symmetry is very important, and we talk about of the reports. And the planned doses are often prescribed to lower isodoses. Again, this is something that is institutional criteria if you prescribe to 80%, 90%. And remember that we have evaluation criteria. We have the high-tech report. We can have RTOG protocols, and we can have institutional evaluation criteria, but be careful implementing this without a review and institutional approval. And here I have the list of the references of some of the, especially for the quantum, the high tech, and the reports for the small field of symmetry. And thank you so much for your attention. And I think we have time for questions.
Yes, yeah. Thank you so much, Cesar. That was an excellent lecture, a very thorough overview of the whole SBRT process, what to pay attention to. I am opening the floor for questions, so please type the question in the chat, or you can also turn on the mic and the camera and ask the question in person if you want. One of the questions I have right now, maybe what are the common pitfalls that you encountered going through transitioning to conventional to SBRT, which happened a long time ago, I'm sure. But if you maybe can provide some examples of common pitfalls.
Well, most of, like, for example, I'm gonna give the example. We started with prostates.
Yeah.
So prostate we started, and of course, the first thing that we started, well, we first of all we made sure that the machines mechanically they are calibrated to SBRT standard. That we have protocols to do that. For example, the coincidence between the radiation field is not 1.5, is less, is 1 millimeter or less. So you need to focus on that. And also we did this a small field of symmetry, but then we were having the main things that we were struggling was with the motion of the prostate and a little motion of the prostate and the motion of the organs around the prostate, especially the rectum and the
Mhm.
bowels, because now we needed to make sure what to do, for example, to push the bowels away from that. So we start doing, okay, why don't we start doing full bladders, meaning we can instruct the patient to drink water right before the treatment. I think it's 45 minutes before. They need to drink 2 cups of water. Of course, this is traumatic experience because they need to hold it for
Yeah.
their delay. They go and release, and then they have to drink again. But that's something that then we got used to it. So that was actually something that we were struggling, and that solved a lot because then you can see how the bowel pushes the bowel, especially the large bowel, away from the prostate. So that was one less problem. We were simulating the patients like that. Also, how to track the prostate, and that was when the insertion of fiducial markers came into play. So we insert this gold in fiducial marking into the prostate, 3 at
Mhm.
least, and normally that's the standard. Why? Because then what we do during treatment, we let's say if you have a machine, which in the dream we have this capability to, which is called IMR, that it keeps taking every, let's say you can say every 5 seconds, it takes you leave the OBI's arms uh, up while the machine is moving with the gantry, and then it takes every 5 seconds it takes a KV a pair a KV image, and then it checks quickly the not a pair KV image. It quickly checks the position of the seats with the position that the seats were in the planning. If they are not in this within 2 millimeters, the machine stops. But you can,
Mhm.
if you don't have that, you can say, okay, every after I treat every arc, I take a KV. I take images and make sure see how the field, and maybe you need to reposition the patient. So those are things that we were, and then it took time for us to develop the best tracking technique. And then it came also when I mentioned about okay, we have the problem of the rectum. The rectum is next to the prostate. So, and we're giving high doses. How can we reduce that? How can we help to reduce or to come across to the constraint for the rectum? So this rectal spacer gel came into it was a solution. And then we started implementing it. But of course, it's a lot of uh, yes, you need to. It's a program. You need to make sure that we're all in the same page, and that the physicians are willing, and the institution is willing to make the insertion of the fiducials and and the shell. And I know that it depends on insurances. So I don't know how
Mhm.
this is costly. I don't know how it's in Ukraine because this is more cost for the treatment. So we need
Definitely.
sure.
Mhm.
So, but like I said, for example, if you let's say the rectal spaces is not an option. We there are institutions that they do SBRT without, but then the margins are different. So the margin between the rectum and the CTV and BTV is 5 millimeter, and then the constraint for the rectum that we follow, they might be a little bit different. You compromise a little more the cover within limits. So there is things to do. But for example, the bladder technique, full bladder, that is something that it can be done. That's free of
Yes.
charge.
Yeah, and it's done many, many
And many
places
places.
and recommended by protocols. Yeah,
Exactly.
so that's
Exactly.
good.
And also,
So
yeah, go ahead.
yeah. Oh, sorry. So we say have participants thanking for the lecture. Thank you so much for the great lecture. And the question from Dr. Sokolowska. Dr. De Biancia, thank you so much for a useful lecture. Is it required to use spacer for prostate SBRT or any other specific conditions for prostate SBRT?
No, it's not required. It's not mandatory. Of course, it helps, but it's not required. But what we do with cases with no spacer, we actually there is a very specific instruction for the bowel preparation for the patients every before they come for treatment from the day before, the morning of, and those are on protocols too. So and that is because you want to try to keep the rectum in the same condition that it was simulated. Okay,
Mm-hmm.
so that's important, but no, it's not a requirement.
Mm-hmm. Because it was at Astro last year, there was a trial that showed that actually there was no toxicity benefits of using the spacer. Even though we are sparing rectum, we think we're
Yeah.
sparing rectum better, but there's no, that
Yes.
doesn't translate into toxicity
Yes.
decrease. Yeah.
Agreed. Agreed.
Yeah.
Exactly. Yeah.
Which is interesting.
Yeah.
So, from a question from Sergei Filkovsky, what about the prostate treatment on CyberKnife, where you can't monitor fullness of the bladder and rectum? What methods would you use? Ultrasound before treatment? How to monitor the
Yes,
fullness?
actually, they do. Actually, the ultrasound they do use ultrasound before treatment to see the filling of the bladder and making sure that the patient follows the second vision. What the patient is being instructed, so you have to go to the bathroom, then drink the 2 cups exactly the 30 minutes before, and hopefully the patient is going to be called on time. So basically, because that's what it was done on simulation too. So, of course, the bladder sometimes acts differently. It gets full quicker and different, but they monitor with the ultrasound. Yes,
Mhm.
because it's not you don't have yes you don't have a combing CT. It's true on a cyberknife.
Yeah. A question from Kirill Teluha. Thank you for interesting and practical lecture. When you use SBRT regimes, 5 fraction, 2 fractions per week, and what constraints do you use? Do you use the same constraints for 5 fractions per week or some other constraints? So that's a very good
It's a
question.
very good question. So
Mhm.
that depends on, for example, for prostate, 800 times 5, we treat the patients every day. But we started doing every other day. So we take a
Ah,
day in between. We started with every other day. And then because of publication and everything, on
mhm,
toxicity report, we came out with every day is okay. And for both regimen, we use the same constraint. We didn't change the constraint. Whatever constraint we have, 8 times. If it's something that is, and for most of the other ones that for lungs, SBRT, we do every day fractionation
mhm,
general.
mhm,
For things that they might, like for example, now we're doing some partial breast radiation, 600 times 5. We're following a protocol that is also every other day. But
mhm.
again, we follow the same constraint. We have a 600 times 5 constraint. And again, yes, this is something that it could be studied, but actually
Yes.
it could
Mhm,
be studied because I understand, for example, 5 fractions, 2 fractions a week is not the same as every week, and these are the things that probably needs to study institutionally, and actually the high tech people did study some of it, and that's what I think the high tech actually recommends the constraint they have to the fractionation that you should do. And they
They
tell,
recommend to fractionation, but they don't specify how
yeah,
many
they have
fractions per week,
yes,
right?
exactly,
So
yes,
that's a drawback. Yeah.
yes,
But
exactly.
that's a very
But
good
it's a very
question.
interesting question that probably yes, I'm sure that there is a lot of things that needs to be studied on that.
Hmm.
But what I will suggest, be consistent with what you choose, what you choose. I mean, if you choose, okay, if you want to choose 5 fractions, 2 fractions a week, do that always and then follow the 5 fractions constraint because we don't have others, and
Hmm.
see what are, you can create a trial, you can create a study. Okay.
Yeah, very good. Uh, Question from Nadia Honcharenko. Thank you for the great lecture. My question number 1 is, in your opinion, what's the best way to immobilize patient for prostate SBRT? And the second question, do you know some marketing a solution for IGRT to correct the couch in rotation? So they don't have 60 couches.
Yeah.
Most of the institutions don't.
Yeah.
Do you know any other solution to
Uh,
correct
yeah.
60?
I mean, to answer the first question, for
Yeah.
mobilization on prostate SBRT in our institution, we treat this patient, they are in supine position, and we use is an aqua plus, is like a net, like the same as the mask for the for the head and neck with little holes, but it's big. And they are basically, it covers from the abdomen to actually including the legs, and you mold everything. And that is the cast, we call it. And then we just make two little holes so we can see the tattoos that we need to do on the,
Okay.
but that's the immobilization. But that's immobilization what we always use for years. Recently, we have a new study that we're doing mold. We call it moldless prostate because we have found that pelvic. I mean, if the patient is comfortable laying on the couch and the right angulation of the legs with a knee
Mm-hmm.
we said, and the knees, the patients do not move. I mean,
Mm-hmm.
there is a good, so you don't need to mobilize on top of that with the cast to the patient. And we're having great results so far. Of course, we're doing a lot of imaging and all that. So, but to start, I will, that's what we use. But there are
Okay.
many studies now that they have. And then for the solution for the sixth of couch that you don't have, uh, what I think, I mean, I know that exact track can give you a little bit of, it doesn't give you the right, it's 2D, it's not a 3D, but it has a combination between that, and it has now like a surface imaging, the
Mm.
new version. So it's a combination of both. So maybe with both you can do a little bit of um,
But you cannot correct the 60 couch
no,
anyways, right?
no.
You can image, but
You
if you
can
cannot correct, that's
cannot
hard.
correct it now because you don't have it. Yes, you don't have it.
Right, right.
The only angle you can correct is just the
Yeah, yeah.
exact, not the pitch and not the yeah.
Yeah. So I see a lot of question from Lina Shah. I guess she knows you. Do you remember her,
Yes,
Lina
of course.
Mystery? Yes.
Yes.
So, okay. Question one: are the fusions performed by dosimetrists or physicians?
Dosimetries.
Dosimetrists. OAR contoured by dosimetrists or physicians, like
Uh,
chiasm cord, small
it's all
bowel,
now. It's auto segmentation now, but
auto segmentation.
by the physician.
Yes, but they are checked by physicians.
Yes.
Auto contouring tool you have at MSK. Which
Yes.
tool do you use? Which tool do you use?
We have a homemade.
Homemade.
We have meme, and meme, within meme we
Yeah.
create a lot of auto contouring, but also we have our own, which is called mate.
Okay, nice. Do you use all high resolution structures for targets and
Yes,
critical
that's a
organ?
very important, especially for small targets and ORs, and especially the one adjacent to the PTVs. We use the high resolution for SBRT. It's kind of like a standard now. Yeah.
Very good. Yeah, it's very important, right? And
Yes.
also small dose grid, and you mentioned that. For
Yes.
SBRT at Stanford, we use minimum 1.5, even 1 if the target is very
Yes.
small. Okay, and that for prostate SBRT, if not using spacer or OAR, do you use dose painting in the overlap region?
Not, no, we don't. What we do, we create that overlap reason to control the dose in order to meet the constraint for the rectum. Basically, what you need to do is you don't want to, basically, you want to give to that whole volume overlap the maximum dose overall in order, because you want to give, because that's part of the
Mhm,
V. So, but we don't do a dose painting. The prescription is not dose painting. It is basically the planning. It is with an overlap structure
mhm.
to help.
And last question from her. Do you use SGRT for alignment like
Yeah,
Vision RT? You
we do.
do?
We use it a lot for brain, all brain
Uh-huh.
aligner T,
Yeah.
for breast, all the breasts, we do aligner T. And then
Mhm,
now with the moldless prostate, we're starting with that because it's a surface,
mhm.
and then we follow with the treatment. Yes, we do.
Okay, Lina, we answered all your questions. Cesar did an amazing job. Okay, another question from Kirill Telucha. If you treat plan on Linux with different isocenter and many arcs, how often do you make control positions as cone beam CT? Or how often do you do cone beam CT, I guess, during
Yeah.
treatment?
During treatment, actually, because we do combine CT at the beginning, just
Mm-hmm.
for matching, and because we use this most of the time IMR, which is we use the OBI to give images with fiducials tracking.
Right.
So we don't use combine CTs in between. But if we used to have machines that they didn't have the IMR option, because that's something that you need to buy extra. So we were doing combine CT every after every arc
Mm-hmm.
or every two IMRT fields, depending. That is depending of the technique that you use. But we were performing just for tracking. Yeah.
Very interesting. I remember your previous lecture, you also talked about IMRT. Do you still do a lot of static IMRT?
Not much.
Not much. Okay.
Not only much. But for example, we have an in-house auto planning. Uh,
Right. Uh-huh.
And for that, for example, for prostate auto planning, we started with IMRT because it was easier. VMAT was much more
The,
complex. So now we're back to 9 fields IMRT for prostate, just because, but it's auto plan. So we don't wait
oh,
planning, but it's 9 fields. But we're developing for VMAT now. So
oh, okay, okay.
in
All
general,
right.
for planning is mainly VMAT, everything.
Okay. So I'm curious about what sites did you automate in the clinic at
We have,
MSK?
yes, for the biggest site is paraspinals.
Yes. That's
Oligo.
how you started. I saw the presentations.
Yes,
That's great.
and that's how we started. And then
Mm-hmm.
then we have auto planning on prostate. Then we continue with prostate. We just started with lungs, VMAT,
Yeah,
then head and neck, some head and neck, some
I
head.
see. Okay.
That's
That's
basically
great.
yeah.
Yeah, good job. Good job. I think auto planning is the way to go.
I know,
It
yes, yes.
really saves a lot of time. But I don't think it's a good solution to do static MRT because it gives more load to the floor to
Yes,
RTTs
yes,
to treat,
exactly.
right? It's
Yes,
9
yes.
beam mode up. Yeah, it's
Yes,
tough.
exactly. So that's why, yes, they are complaining still, but we're
Yeah.
making a nice solution now.
Yeah, that's great. Oh, excellent lecture. Thank you so much, Cesar. So many questions. Thank you for participation and thank you for asking this question. Thank you, Cesar, for answering all the questions.
Yes, of
So
course.
that was a great lecture, amazing, very lively discussion. I'll see everyone in 1 week. So next week we will have site-specific lecture on bone SBRT SRS. And I'll be also sending out a reminder to join in the Prono. So this is the software that you can contour and then you can also check your plan quality. So there will be a lot of practical sessions after these site-specific lectures. So I'll be sending some new information about this. So thank you again, Cesar, for amazing lecture.
Thank,
Um,
yeah,
it was really incredible. Thank you. Thank you. You're a great teacher.
thank
Thank you,
you.
everyone.
Have an
Bye-bye.
amazing weekend. No weekend, day.
Week,
I
day.
want to be.
It's already weekend.
It's a week.
Bye-bye,
Bye.
everyone.